So today our discussion is very important chapter in neuromedicine, that is movement disorder. If you are posted in any of the big hospital, state hospital, and if you are get any chance to attend the neurology OPD, you will see many patients are coming with this movement disorder. This can be seen where in the BRI you can see the patient is coming with different movements, not coming as a normal person. So there are different movement disorder we can detect. Next slide. So movement disorder broadly you can classify it. It is a hyperkinetic disorder where there is excessive involuntary movement. So these movements are involuntary. Even if the patient wants to, most of them are involuntary. Even if the patient is trying to adjust it, not to do the movement, he cannot, because it is involuntary. So it is maybe hyperkinetic, there is more movement, or it may be hypokinetic disorder. Like it is hypokinetic disorder is characterized by paucity of movement, or there is less movement. We also call it bradykinesia. It is a hallmark of Parkinsonism. You know that you have seen many persons having Parkinson's disease, and this bradykinesia or the less movement is a hallmark of diagnosis of Parkinsonism. So it is hyperkinetic disorder or maybe hypokinetic disorder. Prototype is Parkinsonism. Now, clinical approach to the movement disorder, there are several movement disorders, particularly these are hyperkinetic disorders. We will come to the Parkinsonism at the end, but before that we will discuss about the hyperkinetic disorders. So these hyperkinetic disorders are there are examples: Tremor, Dystonia, they are called Tics, Chorea, myoclonus, etc. Most important of these are, you will have to learn it in little details, because sometimes in your exam it comes as a short note. So some detailing will be you should know about this tremor. This tremor you should know details. Some amount of dystonia and chorea you should know details, because in your exam chorea may come as a short note, or tremor, different types of describe different types of tremor, that can also come as a short note or as a short question. So to remember it easily, we can call it ABCD, like athetosis. It is athetosis. It is not written here. This athetosis is also a type of abnormal movement. We will come in details in our following slides. B for valismus, C for chorea, D for dystonia. There are tremor and Tics. This way you can easily remember part of the main involuntary movements you should remember. Next slide is you see where the lesion is. Each involuntary movement, they have a specific lesions in the brain nuclei, like tremors. Tremor are usually divided into, there are several types of tremor. We will come in details, but you should remember at least two types of tremors for your written purpose and also for your practical class purpose. Tremor are mainly, there are resting tremor or Parkinsonism. You know, you have seen a patient of Parkinsonism, they have a resting tremor like this. Even if the hand is kept in rest, patient is not doing anything, the hand is vibrating like these things. These are resting tremor present at rest. This is the hallmark of Parkinsonism. Another type of tremor is cerebellar tremor or intense tremor. The tremor is not present at rest, but when the patient is trying to do an object, reaching for an object, to hold the cup or hold the glass, then there is tremor starts. You know, there is no tremor, but when he wants to hold the glass of water, then tremor starts. So this is called intention tremor. Now you can give the answer. Who can take a cup of water or a glass of water, a Parkinson's patient can easily take a glass of water, no problem, because he has an intention tremor, but when he reaches the object, it stops. So you can take the glass of water, then you keep the glass there, then again tremor starts. So he can take, the water will not spill or spill out of the, fall out of the cup. But if there is an intention tremor, the patient do not have tremor like this, but when it reaches the cup, there is tremor. The patient will not be able to take the glass of water because it will go out of the glass immediately, spill. So another important tremor is chorea. The lesion is in the caudate nucleus. You should remember this, caudate nucleus. In your future, several MCQs you will get. Where the lesion is in the chorea, C for C, you can remember C for C. C for chorea, C for caudate nucleus. It's very important to remember. So Parkinsonism, the lesion, yeah, we have described in one of our class the extrapyramidal system. Now you have seen there that substantia nigra, caudate nucleus, putamen, subthalamic nucleus, these are all the part of the extrapyramidal system. We have described it in one of our previous class. So tumor is all nucleus is the part of the extrapyramidal system or basal ganglia. So tremor is substantia nigra, cerebellar lesion is interstitium tremor is in cerebellum, chorea is the caudate nucleus, athetosis is the putamen, and hemibellismus. This were also a very important MCQ sometimes there. Where the lesion in the hemibellismus, the subthalamic nucleus. We will come one by one, but these are the very important slide to remember where the lesion is. It will help you in answering the MCQs also in your future studies. So with this is a slightly busy slide. You can read it if you can read it. These are all hyperkinetic. These are we are going to discuss today. Tremor is a rhythmic oscillation of the part of the body. Rhythmic oscillation of the part of the body due to the intermittent muscle contraction. This is tremor. There are several types of tremor. At least 2 types I have described. I will come later. Dystonia. Dystonia is involuntary. It is a pattern, sustained. This word is very important. It is sustained. It is sustained. It is sustaining for some time. This word is important for dystonia. This is sustained or repeated muscle contraction, often associated with twisting movement and abnormal posture. Twisting movement, this is like this type of movement, but this is sustained, not that repetitive, not repeating very quickly. It is sustained like this. Dystonia is sustained. There will be cervical dystonia there. So it is a little bit sustained, but athetosis and chorea, they are not sustained. Athetosis, there is a this is little bit slow movement. Chorea, difference between chorea and athetosis is that both are abnormal movement, but athetosis is slow, involuntary movement and affect the arms and hands. Chorea is the rapid. So athetosis is a slow movement, chorea is a rapid movement, semi-purposeful movement. Involuntary, this is also involuntary movement, different group of muscle. When the movement are in the large amplitude, predominant proximal distribution and then. So you should remember these things. The athetosis, what is the difference between athetosis and chorea? Suppose chorea is a very quick movement. You can just to remember, you can take the example of a break dance by Michael Jackson. This Michael Jackson dance, you can compare it with chorea. It is a quick involuntary movement like that, hand and feet and everything. But athetosis is also that type of movement, but it is much slower. You can compare it with a classical Indian dance. Slow like this. Not like this. So one you can remember for your remembers, you can remember this. The chorea is more likely a dance by Michael Jackson, and athetosis is more dance by a classical Indian music. Anyway, so myoclonus. Myoclonus is another involuntary movement. There is a sudden, brief, jerky movement in the muscle twitch and muscle twitches. Tics, very important tics. Tics is very, very common. I have seen in many patients there are some involuntary movements are there. Tics, they are brief, repetitive, short time. But the most important part of tics is that if you can say the patient to stop the movement, he can stop the movement momentarily for some time. Suppose the patient has this type of movement, or some there is some leap movement like this. If you say that stop this movement, he can stop it for momentarily for few seconds. Again, he will start that. This is involuntary, but patient can stop on asking for a moment. He can stop this involuntary movement momentarily for a few seconds. That is the difference between tics and other types. But these all types, dystonia, athetosis, chorea, myoclonus, they cannot stop it. If you want to stop this movement, patient cannot stop it. But movement of tics, habitual movements, patient can stop for some time, for some seconds. Now about tics. Tics, I have told you, it is a recurrent movement stereotyping. Tics are preceded by a rising discomfort or urge, sensory tics that can be released by the movement of the tics. Tics can be suppressed. That is the most important part of the tics. These tics can be suppressed for short period with inner tension, leading to reduced rebound of tics afterwards. So if you can ask the patient, or the patients sometimes when he deep into certain thoughts, he can stop it momentarily, but again it starts. But other movements he cannot stop it. Predominantly in the face, upper arm and neck. This is a repetitive involuntary movement. Now very important part is tremor. This can come as a short note in your theory exam. So I have described this involuntary rhythmic movement. Rhythmicity is important. Rhythmic movement. It is rhythmic. This is rhythmic. This is rhythmic movement. So affect almost all any part of the body, including the head, chin, or soft palate. Tremor often have a variable amplitude but fixed frequency. So I have told you the different types of tremor. At least two rest tremor and intention tremor I have described. See, when there is a present Parkinsonism is a type of rest tremor, or you can call it as a static tremor. Intention tremor is, you can call it as when the patient goes into action. This is called cerebellar disease. These two is very important type of type. But other types of tremor are there also, like task specific tremor, writing tremor. Sometimes the patient may have a no tremor inside, but when starts writing, there is tremor. It is called writing tremor. Patient cannot write it properly. There will be he cannot sign it. Sometimes bank manager, sometimes after that they will not allow to withdraw the money because your sign is not matching. Because the patient has start writing tremor. When he starts to writing, there is a tremor. There is also called writing tremor. There is task specific tremor. Sometimes this may be task specific, maybe music task will come later. It will most commonly we see this writing tremor, task specific. And essential tremor is also a very important tremor. It is actually the most common type of tremor we see. It is a Ransen family. Patients sometimes comes with your nodding of head like this. If you ask the patient, yes, his mother or her mother also has suffered from this type of head nodding in the old age, and that lady also suffering from head nodding. So these several tremors are Ransen family. They also are called essential tremor or family. There is a family history. Usually, in 50% cases, it is also called dominant, but it runs in family. You will get a family history of tremor. Actually, essential tremor is the most common type of tremor we see in the society. Other tremors are also, you have to remember. Now, we have already mentioned some points. This is a very important table. How to differentiate from essential tremor from Parkinson's disease. Because essential tremor, I have told you, it is the commonest type of disorder. Tremor runs in families. So these are the tremor. These are the difference between Parkinson's tremor and essential tremor. It's a longer duration. You see, if you can read this properly. I don't know whether this is bilateral or asymmetric. Parkinson's disease usually it is unilateral to start with. Usually it is unilateral to start with. And this, the tremor of the head and voice. You know that I have told you head and neck may be involved, but Parkinson's disease head neck involvement is very rare. Very rare. Usually do not involve. Head and neck usually do not involve. Writing is normal size but short, but shaky. Here the writing is small, but patient can write. Foot tremor is rare, but foot tremor also can be frequent in Parkinson's disease. And mixed tremor, these are the few differences between essential tremor and Parkinson's. And another important thing is that there is some improvement. You see here it is important. There is some improvement in tremor with alcohol in response to the tremor to alcohol. Essential tremor sometimes reduced by taking alcohol. Okay, so this is important. And Parkinson's tremor there is no, but Parkinson's tremor sometimes the patients tell that smoking can sometimes prevent some amount of tremor in Parkinson's disease. So smoking can reduce Parkinson's tremor, but you should not encourage the patient for smoking for that. But it is just to know that smoking can improve some amount of Parkinson's disease tremor, but alcohol improves essential tremor. That is interesting to note just this point. Now chorea, I have told you, chorea is a dance by Michael Jackson. Word chorea comes from the Greek word called dance. Involuntary movement that are abrupt, unpredictable, non-rhythmic, resulting from a continuous random flow of the muscle contractions. Movement are randomly changed from one body to the other. This chorea can come as your short note. There are different types of chorea, but two types of chorea you should mention in your exam, in your written. One is Huntington's chorea, one is Sydenham's chorea. Sydenham's chorea will come later. Huntington's chorea, Sydenham. The two types of chorea you should know. There are other types also. You may not be able to know, at present you may not know it. But it is Huntington's chorea disease is from the childhood or to the 80s. Huntington's chorea is runs in families. Father suffered and his son will suffer and his son will suffer like this. And usually it is progressive. The father suffers less, son suffers more, and his son suffers more with this Huntington's. Why this? I will come to some explanation. Why the offspring suffer more than their parents? Sometimes it may so happen that we have seen a parent has come with the child have Huntington's chorea, but the parent do not have. But that parent should have, because it is a autosomal dominant disorder. It should have. But sometimes the parents parents will have the disease late. They has come with their son, have the disease. So these things. What is important to note that a child may present before the parent. That was I am trying to tell. In late onset cases, the parent may have no finding. A parent could have died before becoming symptomatic. Dementia, suicide, pathological illness, these are common. The most important part of the Huntington's disease should be correlated in the case of chorea. So important these things are. What is the important MRI finding of chorea? You know the chorea. C for C, I have told you that the lesion is in the caudate nucleus. There will be caudate nucleus will be degenerated and size will be small, and the caudate nucleus is surrounded by lateral ventricle. So MRI finding will be atrophy of the caudate nucleus and enlargement of the frontal horn of the lateral ventricles. Because the caudate nucleus is shrink, then by the side the ventricle will enlarge. So this is the important finding of the MRI finding of the caudate nucleus. This is for your MCQ. If you go further studies, you will get this type of MCQs. So what is the MRI finding of caudate nucleus? Okay. A diagnosis is by genetic testing. I have told you it is a genetic disorder. Genetic. What is this? It is Huntington's repeat gene, HTT gene mutation, CAG repetition for more than 27 times. This, you know, this Huntington, here it is described little elaborately. Huntington typically, this is a gene. Gene is called HTT gene or Huntington gene, called HTT gene. It is actually, this gene is in chromosome number 4. The disease, the gene is present called HTT gene. How this gene is formed? There is a triplet called CAG. See, you know that these are nucleic acids. Okay, adenine, guanine, and cytosine. The cytosine, adenine, and guanine. This repeat, they comes in a normal normal chromosome number 4. There are CAG is there. This nucleic acid will come sequentially. When it come, we call it a triplet. When they come sequentially, after cytosine there is adenine, there is guanine. This if this comes sequentially, called a CAG gene. Everybody has CAG gene in his chromosome number 4. But this CAG gene will repeat it. It's a long chain of chromosome is a long chain of nucleic acid. So the CAG will repeat. In a chromosome number 4, that will repeat. But this repetition is more than 27. It should be, then the symptoms of Huntington's chorea will come. So this is written there, this CAG repeat. You can now understand this word. What is repeat written there? Is a CAG repeat more than 27. This triplet repeats in the chromosome number 4. More than 27, the patient will be symptomatic. Otherwise, if it is less than 27, usually they do not become symptomatic. So probably this is clear. Now, if this is that, then now you can now understand this word. Huntington's chorea is typically, there is a HTT gene called chromosome number 4. However, up to 10% of cases due to the Huntington's protein. This gene, this CAG, if there is a CAG repeat is more than 27, that will produce a protein that will damage the caudate nucleus. That is the pathogenesis. The abnormal protein produced by the CAG repetition in the chromosome number 4 will produce an abnormal protein that will damage the caudate nucleus. This is the pathogenesis of the Huntington's chorea. Whatever it is, now you can understand this expansion of CAG repeats, called this trinucleotide repeat expansion in the gene is in the coding the Huntington's protein, resulting in abnormal mutant protein, which will gradually damages the brain cells through the number of possible mechanisms. Another important is Sydenham's chorea. Sydenham's chorea is found in Sydenham's chorea is a neurological disorder that occurs in a combination of acute rheumatic fever. So Sydenham's chorea is a complication of acute. This is a symptom of acute rheumatic fever. You know that acute rheumatic fever occurs how? It is a streptococcal. There is a streptococcal infection in the throat, and the body produces an antibody called anti-streptolysin O against that streptococcus strain. That anti-streptolysin O, they erroneously cross reacts with the some part of the body. What they should not. How they when they reacts with the endomyocardium is the heart, they most commonly affect the heart, affect all the layers of the heart, endocardium, myocardium, and pericardium. All the layers of the three layers of the heart can be affected by the cross antibody reaction of the streptolysin O. That's why in rheumatic fever, we always ask the patient whether you have a streptococcal sore throat, because that's at that time of the disease, patient will not have streptococcal disease, but this antibody produced by the body ASO that cross reacts with the heart produces this pancarditis or rheumatic carditis. That same antibody can react with the basal ganglia also. As they affect the heart, they can also affect the basal ganglia. So when they affect the basal ganglia, then some chorea will be there. You know that chorea is caused by this caudate nucleus is the part of the basal ganglia. So when they involve the caudate nucleus, they will have chorea. So rheumatic fever can have, as they have carditis, they can also have a rheumatic chorea. So rheumatic chorea is a complication of the streptococcal disease. Cause after a streptococcal throat infection, the immune system mistakenly attacks part of the brain, especially the basal ganglia leading to abnormal movements. As they affect the heart, they can also affect the basal ganglia. They also affect the skin also. No, we know that acute rheumatic fever, there is a rheumatic nodule. They affect the skin. Similar rheumatic nodule may be produced in the lung. So they cross reacts with the this substance, this antistreptolysin O, they cross reacts. So two types of chorea you should remember well. One is Huntington's chorea, one is Sydenham's chorea. Now come to dystonia. Now I will little because this is a I little quickly I will pass off. Dystonia, involuntary movements. There is a coordination of that. This is the most important part of dystonia. Is it is sustained, little bit sustained. Abnormal characteristic posture and movement produced by slow sustained. Giving the word sustained, we keep the stress on this word sustained. Muscle contraction with distorted trunk and sensory trick, sometimes touching trick, or this can give rise to this dystonia. Now, task specific, there are task specific dystonias, like the movement of the posture are predominantly, or even the writer's cramp is a type of dystonia. Actually, musician is dystonia. Writers have two types of dystonia. I have already described the writer's tremor. Tremor. Tremor is that the distal fingers are affected, but dystonia, the wrists are affected. So, what will happen? The patient will hold the pain and starts writing, there is cramp. But here, if there is a due to dystonia, patient will not, when trying to hold the pain, starts trying this dystonia, sustained movement. Patient cannot hold the pain properly. So, this is little proximal involvement. So, writers during writing, there may be writing tremor or maybe writing dystonia also. So, caution, this patient is have leg dystonia who have specific difficulty, bring along the relevant equipment, asking the patient to the video, because sometimes we ask the patient to make a video in your home, what type of movement it is, then come with the video in your OPD, then you can diagnose it properly. Now, very important, this is Wilson's disease for your exam purpose and also for knowing. Wilson's disease, this disease of copper accumulates in the liver. There is a copper accumulation due to it is autosomal recessive disorder by which there is a copper accumulates in different parts of the body. Mainly it accumulates in the liver, in the brain and in the cornea. These are the three major organs where the copper deposits. In the liver it causes hepatitis, definitely jaundice and cirrhosis of liver. And it also causes affects the brain, causing encephalopathy. This liver can cause encephalopathy also. And it also deposits in the caudate. This same copper may be deposited in the caudate nucleus, that will cause dystonia and ataxia. Then your answer will be Wilson's disease. Right. So, this Wilson's disease is the heavy metal poisoning. It is heavy metal, copper is a heavy metal. So, the treatment is penicillamine. Penicillamine is uses in many heavy metals toxicity. So, like this also, it is treated with penicillamine. So, diagnosis by how can you diagnose? You place cellulose plasmin is low, the serum copper is not useful. Very important, serum copper is not useful for diagnosis. For 24 hours uric copper you can measure, there will be excess of copper. Looking for the KF ring in the eye. It is also, I told you, it is also affect the cornea. When the copper deposits in the cornea, you will get a KF ring around the people in the iris. In the cornea, there will be copper deposit. You will get a ring-like structure. This also is important. Is KF ring, Kayser-Fleischer ring. In short, it is called KF ring. Very important to remember. This KF ring is the hallmark of Wilson's disease. It is autosomal recessive disorder. Siblings may be asymptomatic, but have biochemical evidence of copper excess. In autosomal dominant disease, the offspring will be affected always, but also in autosomal dominant disease. But autosomal recessive, the next generation may not be affected. Anyway, in this way, this Wilson's disease occurs. So it will come in your exam when there is if you get a case of jaundice. This questions of Wilson's disease may come. Now, myoclonus. This is very shortly, sudden brief involuntary muscle jars can occur at the wrist or may be triggered by movement. Epilepsy you can also consider. And hypoxia and metabolic disorders can bring this type of myoclonus, jerky muscle movement, neurodegenerative disease and medication as the causes of this. This myoclonus is usually treated by clonazepam, levodopa-carbidopa or by valve fluid. So it is a spontaneous at rest during movement, action or provoked by tactile or acoustic stimuli. These are myoclonus movement. Now Bellism. Bellism is also another type of involuntary movement. This is usually lesion is in the contralateral subthalamic nucleus. This is very important to know. Bellism is like athetosis, but almost more muscles and more proximal muscles are involved. Like the whole half of the body is involved. Then we call it as a bellism, hemibellism. So due to ischemia or hemorrhage in this subthalamic nucleus. Very important to know that the area affected is subthalamic nucleus. So treatment is by dopamine receptor blocking drugs like haloperidol. When it is affecting the half of the body, we call it hemibellismus. When the whole of the body, we call it bellism. There are other movement disorder also, like this is very important disorder called tardive dyskinesia. Tardive dyskinesia or tardive movement disorder, we call it also TD, tardive dyskinesia. This is produced by, it is also previously called EPS or extrapyramidal syndrome. EPS, extrapyramidal syndrome, that was the old term of this tardive dyskinesia. Now you should use this term called tardive dyskinesia. The EPS is a very common in if you do an emergency room, you will see that patient, the anxious parents come with their child. From the morning, my child is, the neck is moving like this, and the tongue is moving, eye is moving like this, and abnormal type of movements are there. The parent is very anxious. How it occurs? On examination, you will see there is an involuntary movement, and on inquiry, you find that there is a history of taking some drugs that causing this tardive dyskinesia or extrapyramidal syndrome. Most common drugs used are antiemetic drugs like your haloperidol, antiemetics like domperidone, metoclopramide, domperidone, and many drugs can cause this extrapyramidal syndrome or tardive dyskinesia. Even some antimalarials can cause. Nowadays we use many gastrointestinal drugs that are used can cause this lisuride. Now they are using levosulpidide. Levosulpidide is very notorious, sometimes very much persistent in levosulpidide. This type of tardive dyskinesia. So this due to smacking, there is smacking, tongue protrusion, chewing movements like this. There are psychogenic movement disorder also. You read it. Now treatment of hyperkinetic disorder, you know that this, I have already described all these type of disorders. Dystonia can be treated by anticholinergic like baclofen, botulinum toxin, like this. And DBS is deep brain stimulation. DBS, deep brain stimulation. This is an intervention done by the neurosurgeons. I will come later a little bit. This hemifacial spasm is another important cause. We give it a botulinum. Sometimes the botulinum toxin is injected in the muscle involving, then it becomes relieved. So botulinum toxin injected in the muscle also. This is essential tremor. Is a familial tremor. I have told you can be treated by propranolol. Very effective drug giving propranolol, primidone, and the thyrotoxicity also can cause tremor. No, thyrotoxicosis that can cause tremor. That tremor is also very responsive to propranolol. Primidone, topiramate, botulinum toxin, these are the other drugs can be used in essential tremor. But very important drug is propranolol and primidone, you can remember. Tics, Tourette syndrome, tics. These are fluphenazine, botulinum toxin and risperidone can be used. Chorea, Huntington's chorea, tetrabenzene sometimes gives some, actually there is no treatment for Huntington's chorea, no treatment available, but tetrabenzene sometimes gives some relief. Myoclonus, I have told you, this is clonazepam, levodopa-carbidopa, these are the treatment. Tardive dyskinesia, this usually it is caused by drugs, so withdrawal of the offending agent is important, but can be responding to tetrabenzene, botulinum toxin. Sometimes it is also responsive to benzodiazepines also. Now we will come to the Parkinson's disease. Now, these all previous movement disorders were hyperkinetic disorders. Now, Parkinson's disease is a hypokinetic disorder. So, it is a bradykinesia, less movement, low, uh, very slow movement, less than normal. So, this is bradykinesia. This is the important diagnosis. So, what is the path? There is a loss of dopaminergic activity in the substantia nigra. I have told you already. This is the dopaminergic activity is less in the substantia nigra, leads to dopamine depletion in the stratum. So, it is treating with dopamine, no? But dopamine cannot reach the brain. That I will come later. But treatment is by giving dopamine. It is caused by depletion of dopamine in the substantia nigra. So, treatment will giving supplement of the dopamine will be the treatment of Parkinson's disease. So, it is caused dopamine is caused by depletion of the imbalance of the dopamine and acetylcholine. So, there is a delicate balance between dopamine and acetylcholine in the basal ganglia. This relation disturbance ratio is lost between dopamine and acetylcholine. Reduced direct pathway and indirect pathway, this is there. You may not remember these things, but remember at least these few lines. Now, Parkinson's is a primary Parkinson, maybe secondary Parkinsonism will come later. But what I have described is the Parkinson's disease is the primary Parkinsonism. It is also called paralysis agitans. Another name of this is paralysis agitans. Pathology is depletion of the pigmented dopamine neurons in the substantia nigra. The cardinal features of Parkinson's disease is tremor, bradykinesia, and rigidity. So, these three is very important. Bradykinesia I have already told you, less movement. Patient has the intention. There is a static tremor. I have told you static tremor. There is bradykinesia, and there is rigidity. There is rigidity means the contractile state of the muscle is increased. So, there is rigidity will come. A fourth features, postural instability is also very common. So, this is the part of the substantia nigra, the extrapyramidal system, where the lesion is. Now, this very important slide, you should remember at least, if the Parkinsonism has come as a short note, you should write at least these points to get at least a few marks, just pass marks. So, what are the features? Remember these things: tremor, rigidity, akinesia or bradykinesia, and postural instability. Tremor is a resting tremor. I have told you, it usually starts with it is unilateral and also called pill rolling type of tremor. What type of this tremor is called pill rolling type of tremor? This can be asked in your exam. What type of tremor it is? It is called pill rolling tremor. Rigidity, I have told you there is rigidity. There are two types of rigidity: late pipe rigidity and cogwheel rigidity. We have heard the term the clasp knife rigidity in our corticospinal tract lesion. Clasp knife, no? At the initial part there is a rigidity, and rest part of this is normal. Then again rigidity. So, but here late pipe is throughout the movement there is rigidity, and cogwheel is jerky rigidity. This is cogwheel rigidity. So, this rigidity is a late pipe rigidity or cogwheel rigidity. Bradykinesia, difficulty in initiating and slowness of movement. Patient is if he is asked to start the movement, patient hesitates how to start the movement. He thinks, then he forward his steps very slowly. So, it is bradykinesia, difficulty in initiating, impaired balance, or may lead to fall also. There are other this is about primary Parkinsonism, also called paralysis agitans. But there are secondary Parkinsonism also. The features of Parkinsonism develops due to some secondary causes, like drugs. These are the methyl-dopa and some methyl-dopa. We give it, is antihypertensive drug. We give it, and these toxins like carbon monoxide, manganese. As there is infections, like encephalitis and syphilis. Post-encephalitic Parkinsonism is also not very uncommon. It also occur post-encephalitic Parkinsonism. We will classify this as a secondary cause. Trauma may be there, maybe Wilson. After the Wilson's disease can also give rise to Parkinsonism. So, there are different types: vascular Parkinsonism, drug-induced, atypical Parkinsonism. But you remember these things. The Parkinsonism can occur secondary to encephalitis, different drugs and like this, and there is one primary Parkinsonism where no such offending agent is present. Now you should examine the gait. What the gait? It is a slow start walking. I have told you it is walking starts very slowly and start walking. That is shortened stride, very small types of gait, and is also called Festinant gait. This type of gait is very important to remember the term called Festinant gait. There are different types of gait I have described in your just last class, that there are different types of gait. This is also another type of gait called Festinant gait, occurs in Parkinsonism. So there is reduced flowing, impaired balance, the physics of gait. And so, but in this slide, most important is what type of gait you find in Parkinsonism. It is a Festinant gait. You should remember at least this term, Festinant gait. Now features, I have already described the features of tremor, resting tremor. This is also called pre-rolling tremor. Tremors in the arms, legs and feet. Tremor usually starts unilaterally but later becomes bilateral. It appears later in the lips, tongues, etc. Tremor disappears during sleep. During sleep, patients do not have these tremors. Now there are some eye signs of Parkinsonism. There is decreased blinking. There is some amount of blinking in your eyes always there, but there is decreased blinking. It's called staring look. If you look at the patient looks at stare. There is blinking of the eyes are less, so there is a staring look. Look will be staring, decreased blinking. There is hypometry saccades. Saccades are the movement. When you follow a moving object, there is suppose you are running in a train and you are looking at object outside. Then there is a sudden movement of the eye, right side. Then there is gradual back up. The eyeballs gradually back up in the backs in the middle. So the sudden movement is called saccades. The saccades movement will be very slow in here. The broken pursuit and globular tap. This is very important. Another, the globular tap, what is called Meyersson sign. If you from the back of the patient, if you tap the glabella, if you examine it any of your friend, you tap the glabella from the behind like this, there will be some amount of blinking, 3, 4, 5 blinkings, then the blinking will stop. But in Parkinson's patients, they will go on blinking this patient. This is called Meyersson sign. So if you from the back, if you tap the patient's forehead, the patient will go on blinking, he cannot stop it. But if you do it any of your friend, they will stop it after 3, 4 blinking. Here the Parkinson's patient cannot stop. This is an important sign called Meyersson sign. This Meyersson sign in your exam, if there is a Parkinson patient, the examiner will ask you to show this glabellar tap sign or Meyersson sign. So management, I have told you what management is due to imbalance between acetylcholine and dopamine in substantia in Niagara. So these anticholinergic drugs will help you, and there is Levodopa and Carbidopa. The dopamine will not cross the brain, so but Levodopa will cross the blood-brain barrier. That's why Levodopa is used. The levo isomer of the dopamine is called Levodopa. That Levodopa is used because that can cross the blood-brain barrier. And when you use the Carbidopa, then it is written here. You see, the Carbidopa is used just to avoid the distractions. This is a drug is destroyed by the Carbidopa will avoid this Carbidopa initial dose. The Carbidopa, if you add Carbidopa, that will prevent the destruction of the Levodopa peripherally by carboxylase inhibitions. So the most common drug used and initial drug used is combination of Levodopa and Carbidopa. But you can use anticholinergic also and amantadine also. Now, this is slightly laboratory of management. Dopamine receptor agonist, management. These are also drugs used like dopamine receptor agonist, like bromocriptine, carbagoline, etc. They can be used in Parkinsonism. They can be either, at least we should remember previous drugs. But these drugs are also in use, like COMT inhibitor, catecholamine methyl transferase inhibitor, entacapone, levodopa. These are the drugs when you cannot control it with carbidopa, levodopa, amantadine. Then all these drugs are in use because it is a disease, progressive disease, and very difficult to control. Now, MAO inhibitors are also in use for Parkinsonism. Like you see, there is a MAO inhibitors. It may slows the disease. That used is in a levodopa along with levodopa response fluctuation. So, here you see there is the important finding because on-off phenomena. This is very important to remember when you are treating the patients with carbidopa levodopa. On-off phenomena. If you withdraw the drugs, immediately the symptoms will come. So, on-off phenomena is an important feature for levodopa-carbidopa therapy. Now, MAO inhibitors are in use like resagiline and cefagliline. These are MAO inhibitors are also used in this inhibitor. Now, this is the last slide probably. Deep brain stimulations. Nowadays, various diseases like this involuntary disorder, not only Parkinsonism, various diseases nowadays are treated with deep brain stimulation. This is actually done by the neurosurgeons. They actually implant a device inside the brain. They implant a device inside the brain like a chip in your brain that will prevent this involuntary disorder. You can read this if you are interested. That this stereotypic insections of the electrodes into the brain is a major therapeutic advances in the selected patients. These are the very promising and nowadays very much using Parkinson's disease and also on dystonia, different types of dystonia. The neurosurgeons are nowadays treating by putting a chip that will discharge a electric discharge like your pacemaker. There is a pacemaker in the body. There is used in the heart like this. Same like pacemaker, electric discharge. This is by a chip. They put it inside the brain for deep brain stimulation. So, deep brain stimulation is a stimulation technique which this deep brain stimulation can also come as a short note because nowadays it is very much in use. So, it can come as a short note deep brain stimulation. So, it should write it at least this thing where it is used. So, it requires this the surgical implantation of a neurostimulation, a battery powered device which coordinates neural interference by sending pulse electricity through an insulated wire into the electrode. What I want to tell, the location is in the electrodes at the tip, which the wire is generally decided on the symptomatic basis, with the help of an MRI or CT scan to identify the region of the interest. This is just a picture how this device is implanted in the brain. That will when there will be excessive discharge from the dopamine or there is less discharge from this extrapyramidal this quadratic nucleus or like this, they will act accordingly. They will suppress it or they can stimulate it also. In this way, the deep brain stimulation is used. So, let's we finish this class today, and the next class will be on probably the last class on neurology lecture. There are some other movement disorders are there, mainly gait abnormalities.